बिस्मिल्लाहिर्रहमानिर्रहीम। डॉक्टर उज़ैर,
Yes, sir.
कैसे हैं आप? ठीक है?
Alhamdulillah, sir. Taj.
So we are taking the long case,
Yes, sir.
and this is just a new system of virtual examination.
Yes, sir.
It will be like same as the examination long case held for 1 hour. First half an hour shall be like history taking, presentation of history and examination and differential diagnosis. It will be virtual. Basically, I will show you certain slides, certain photograph. I will ask you questions and you will reply. Phase wise, it will be an interactive dialogue system. It is not like that previously we sit down and listen what you are doing and we watch you what you are doing. Here it will be interactive system and phase wise. Whatever we will ask, we will give you the marks as you reply, or all marks are distributed as previously, right? So are you ready?
Yes, sir.
Okay, so Bismillahirrahmanirrahim, we take the first slide. Here is the boy, 9-year-old. He fell from 5 feet height from a tree while playing 6 months back. He has an pain and antalgic limb on the left side. Okay, what additional questions you will ask to reach the diagnosis and differential diagnosis? Please reply.
Sir, we have the initial information that there is a fall 12 months back.
Speak loudly. I am not able to listen to you. Others should be mute. Okay.
The patient has issued a fall 12 months back, and presenting complaint is pain and antalgic limb.
Yes, 5 feet height. Yes.
Yes, sir.
What else question you will ask? Diagnosis.
Sir, I would like to ask about the initially the treatment treatment given to the patient initially after the fall.
Okay.
And associated injuries, injury to the head injury or spine injury.
Okay. Okay.
And I would also like to ask about status of the limb when it was injured. I would like to involve the parents like that.
Okay. Okay. What else you want to say from the patient? You want to listen any more? Anything?
Sir, I want to. I would like to ask about his birth history.
Birth history. Okay.
What was his mode of delivery, and what is the health status of the mother, and what was developmental milestones.
Okay. What else?
Then I will also like to ask about the immunization history.
Okay.
Then I'd like to ask about his present ambulatory status. What is he ambulatory or not? And can he sit or squat? Can he use the Indian toilet? And
Okay.
yes. And can he dress himself?
Okay.
So, can he?
If you are complete, then I will let you know the all answers. Okay.
Yes, sir.
When you complete, please let me know. Okay.
Then
dressing, self-dressing. Yes.
Then I'll also ask about.
Okay. Hello.
Yes, sir.
Are you listening me?
Yes, sir. Yes, sir. Yes, sir. I'm listening, sir. Sir, stop.
Stop listening. Hello.
Yes, sir. I'm listening, sir. Please.
There is interruption in the system.
Sir, I can hear you, sir.
Okay, you want to answer to these questions now?
Yes, sir.
Okay. So he had a fall from 5 feet height while he was playing with his friends. And after fall, he was not able to stand and bear weight. Okay. He has no associated injury like head injury or wrist or spine injury.
Yes, sir.
And he was basically able to sit, but not able to walk or stand and bear weight. Okay. For the 2 days, then he was taken to the Potter's Kumar, where he got splintage in the treatment. Regarding the bus history, he is absolutely normal history and vaccinated. He was vaccinated for tuberculosis as well, and his developmental history was absolutely normal. No delayed milestone, spasticity, etc. Right? Are you listening? Hello?
Yes, sir.
Hello?
Yes, sir. I can hear you, sir.
Hello? Sir, you hear me? Hello?
जी सर आपकी आवाज आ रही है सर.
At work nowadays after 6 months of injuries, but he has a significant limp and the pain. He can dress himself easily.
Yes, sir.
Okay, what else you want to know?
Sir, I want to know about the expectation of the parents actually.
Okay,
Then I'll also want to know about the cognitive status of the child. Is he going to school? Is he good in studies?
he was cognitively normal, but nowadays since trauma, because of the pain and limp, he's not going to the school, but he want to go to the school. And he want to be a normal human being, and he want to cover his limp as well.
Yes. Then,
What else?
then I'll be.
Is it sufficient?
I'd like to know some shortly about his family history or any allergies he has, or any systemic problem he has, including epilepsy or pulmonary issues.
Okay, his family history, he has three siblings and the father and mother. They are young laborer. They are normal. They have no disease any chronic illness in the family. He himself has no history of any chronic illness in the family himself, and no systemic illness. Okay, what else you want to know? If it is sufficient, then we can move next.
Yes, sir. I think we haven't missed anything. And any other medical condition, past medical history, any treatment taken for any other?
Absolutely not. Except this Potter's treatment, he has not taken any treatment. He was a healthy boy. Okay, that's how we move to the next slide. Now you know about his history in detail, family history, socio-economic history, and the personal history, right?
Yes.
Now, how you would like to proceed to reach the diagnosis?
Sir, I would like to do thorough examination of this patient with full exposure and consent.
Okay, you take the consent. What do you want to know in examination? What do you want to do in the examination?
Sir, I'll start with the proper exposure of the patient, as the patient are already exposed. I'll do the
जनरल करूंगा, सिस्टमिक करूंगा, लोकल में क्या?
Move.
Yes, sir. I'll do the general examination initially very quickly, and then do the systemic examination. Listen to the chest and palpate the abdomen, and I'll make the patient stand and look from the front, side, and back. And
Okay.
yes, sir. I'll see the findings. I expect to see pelvic obliquity, limb length discrepancy, and or any any form of atrophy of the muscles, of the leg muscles. And then I'll ask the patient to walk and look at its gait.
Okay.
Yes, sir. And the expected gait
Okay,
is.
Dr. Saab, okay. You said that you want a general physical examination. I would see just having a small cuff in the chest. Otherwise, he's okay. His pulse, BP, and normal. Since beginning, he's normal. At the 6 months for trauma now today, that's absolutely normal, except locomotor system. Okay. So locomotor system, he is a limp and painful limp. It is entalgic limp, and he's not able to walk a long distance. What focused clinical examination you can do?
Sir, as I started with the inspection, I'll complete the inspection from the back side also, and from the sides. I look for increased lumbar lordosis and any compensatory flexion of hip and knee at the normal side, and then I'll do. I'll make the patient sit and squat and stand on his toes and heel. Then I'll.
So what this will tell you, this posture, front, back side, tiptoe, what do you want to know about among these clinical examination in focused musculoskeletal system?
Sir, from front, I want to see the pelvic obliquity and the lymph node discrepancy actually, and any atrophy. From the side, I want to see increased lumbar lordosis and attitude of the normal limb, and the any loss of plantar arches. And from the back side, I want to see status of the gluteal muscles, gluteal appearance, and I want to screen the spine for any
Okay.
anomalies, and also I want to see any cafe au lait spots or any stria or dimples on the back side, or any abnormal tuft of hair.
Okay. So, Dr. Saab, why do you want to see the lordosis? You said that you want to see lordosis.
Sir,
What does it indicates? What is it? Is it here lordosis in this particular child?
sir,
If you look on this, if you look on this slide and also on this slide, can you find a lordosis?
no, sir, it looks fine to me, but
Okay, if a patient is having a hyperlordosis, what does this indicate clinically? If you find
hyperlordosis.
honestly,
Yes, sir. Can be due to compensated due to dislocated hip, or compensate the abductor weakness, and also.
abductor weakness.
Yes, sir.
Okay. And what about you said like the plantar arch you want to see? Why you want to see a plantar arch in this particular case in the cafeo alatus part?
Yes, sir. So in this case, due to atrophy of the muscle, the arches can collapse.
So you mean you want to go something diagnosis, something musculoskeletal disorder, weakness,
Yes,
like that?
I want to rule out all the neuromuscular weaknesses also.
Can you find in his feet any arch like that?
Yes, sir. I didn't get it, sir.
Do you find any arch in this patient or no arch?
Sir, I can't see the arches. Actually, the both feet are actually joined, so I can't comment on the arches at this time.
Okay. What about the capsuloalatus part you said?
Yes, sir.
Any disorder which produce this like this condition related to capsuloalatus part? Any pathology which is related to the capsuloalatus part in this particular case? Hello?
Neurofibromatosis is in.
Hello? Speak.
Sir, neurofibromatosis is a disease having
How you,
cafe
that will help you? How how that will help you in this particular case?
in this case.
Okay, Dr. We move to the another question for performing certain specific tests.
Yes, sir.
Now I will ask you virtually, but we can in the exam we can place a simulator. You can place a simulator on the couch, and your examiners are there. Second examiner is there, and I will ask you a certain test. Can you enumerate certain tests which is possible help you diagnosis in this particular case? Just enumerate. Specific posture you had, squat you had, screening you already.
Galeazzi's test, Krenelberg test, and Thomas test.
Galeazzi, Rendlingberg, Thomas,
Yes.
what else?
Then
Related to this particular.
sir, measurement of individual bones and branch triangle measurement.
LLD, yes?
Yes, sir, measurement
Okay.
of LLD. Then
Okay, one of the
range of
friend
motion.
must be on the coach, and the Dr. Zahid will look after second examiner as a second to check the test. That okay. What else? This was the Galeazzi, Orunke Trendlingberg, there was Thomas, there was LLD, there was Branch. What else? Anything else?
The range of motion. I look for range of
ROA.
motion, sir. Yes.
Okay, ROA. What is the difference between the Galeazzi and LLD in this particular case in Briance?
So in this particular case, Galeazzi is expected to be positive. The femur is expected to be short, and in branch triangle, I expect that the branch triangle may be inverted, or
Okay.
any of the quadrants may be smaller.
Okay. What about the LLD?
There will be LLD, sir.
Why you want to see LLD? Yes.
Sir,
Okay.
I am expecting a pathology around the hip actually, and I want to see LLD to assess that, sir.
So all these three trays, Galeazzi, Branch, and LLD are for the
For a lymph
purpose lymph inequality.
Yes.
Okay, good. What you do in LLD?
So on LLD, sir. Sir, on LLD, sir, I expect that as there is history of trauma, I expect that there is some problem with the hip, which is causing LLD. And I have to correct that.
What type of LLDs you measure?
Sir, in measurement, sir, I mark the anterior superior iliac spine.
I'm not asking how. I'm asking what. What two things you see in LLD measurements?
Sir, apparent the LLD and true LLD.
Okay, if there is a contracture of adduction, how you will measure the apparent?
So apparent, there is no need of changing of position for apparent shortening, but for true shortening, I have to square the pelvis first.
That's great. Okay, look at this gentleman. And Sam, can you be done a simulation on your before Zahid? Any person can do like this. What you see in this patient when he is standing on the right side? Which specific test we are performing by standing on one side and then on other side? What is that called?
So Trendelenburg test.
That's good. So what is happening when he stands on the right side?
On the right side, the sound side sags. There is a sagging of pelvis on the right side. On the left side,
Are
sir.
you sure that there
On the left side, sir. Sorry.
is there any sagging? Is there any sagging on the left side?
No, sir.
No. Then what you say in this test of
Sound side,
the
sir.
trembling bug, it is normal or abnormal? This
So
side.
on the right side, it's normal, sir.
Okay. Look at the next. So he stand on the left.
Yes,
And
sir.
what do you feel now?
This is positive, sir. Tremor is positive.
How do you say it is positive?
The weight is going to the right side.
Let me know. What?
The weight is going to the right side, sir. The right side is sagging
Weight-
down.
Right side is sagging. How do you say it is sagging? Compare this, the previous one. Compare this previous one.
Yes, sir.
And compare this. How do you say it is sagging?
Sir, as the patient is trying to maintain his weight on the left side.
Okay.
Yes, sir.
So he's trying to maintain. Why he's trying to maintain? What is happening? What is the problem?
Sir,
I agree with positive.
sir,
So there is a drooping. There is a drooping. If you draw line this and they see that these gluteal folds, there is drooping on this side. So what the inference comes on this? What is your judgment? Why so happens so?
it happened. It can happen because of two things. One is abductor weakness, sir, and second, it can happen due to an antalgic hip, sir.
Second is
Painful hip, sir. Painful hip.
painful hip.
Yes.
Usually painful hip. We don't do and don't take support. Okay. Any other thing? What are the three components of the Trendelenburg test? Three components of the Trendelenburg test, pathophysiology.
Sir, one is the abductor deficiency, sir.
One is power.
Lateral power. Second is failure of the fulcrum, any pathology in the hip.
Okay.
And
Fulcrum.
third
I'm not asking you. I am asking you just component. Fulcrum. Next.
next is the neck, the liver arm, sir.
Liver. So three component. Any problem in this may produce a Trendelenburg. Okay. So what do you expect in this particular child? Which component is a problem?
Sir,
Power, fulcrum, or load?
Sir, it looks like the problem with the fulcrum.
Okay. We move to the next slide. We have already done this pathophysiology, and we move next slide. What this test is for, and what is happening in this test? और ये जायद सामने कर भी सकता है. Anyone can do some in front of the you all.
Okay. The Thomas test.
Okay.
We are doing Thomas test in this case, sir.
Are you sure this is Thomas test?
Yes, sir. Yes, sir.
What are the problems or flaws in this particular test being done?
So when is that the hand is not under the lumbar spine to see the lumbar lordosis.
Okay.
Second is that the flexion contracture at the knee is not overcome
How you will exclude? Okay,
keeping
right. Okay. How you exclude the knee contracture?
So I'll exclude it by putting the patient on the edge of the table.
Edge of the table. That's good. Okay. Now, any more tests in the planning that help you? We had the Trendelenburg, we have the Thomas, so range of motion and the Beranseng we almost has been done. Okay.
Yes.
We move the next slide. Okay. So leg length inequality, how you will this detect the apparent and the true here?
Yes,
We already have the questions. You can draw the imaginary line here.
Yes.
Okay.
First, I'll palpate the anterior superior iliac spine and mark it.
Okay.
Then I'll palpate the greater trochanter, tip of the greater trochanter, and mark it. Then I'll flex the knee and palpate the medial joint line and mark it.
Okay.
And then I'll mark the medial malleolus,
Okay.
tip of the middle.
So, is there any other test to check the limb length discrepancy?
Galeazzi's test, sir?
वो तो already we had, वो तो कह चुके हम.
Yes, sir. Or sir, tibial height on in prone position
Hmm.
and
Tibial height, front position.
yes, sir.
For what?
For tibial shortening.
Okay. Let me know which is what, right and left.
So, so the right
ये
one.
सी है.
The right one is the apparent length, and the
This
other
one.
yes, sir. The other one is the true length.
So now we come to the differential diagnosis. Almost examination we have done. Can you recall the findings as on the screen? Please let me know what were the findings and what was the history.
Sir,
It is written there, 6 months old.
ये पढ़
Yes,
लेना
sir.
ये जो finding
Sir,
आपको।
my patient, 8-year-old boy, presented with a history of fall 6 months back. He is presented with an intelligent
So
pain.
he is I let you know, positive Tendling burst, positive Thomas test, 1.5 centimeter true shortening. Brand shortening is again 1.1 centimeter. Okay.
Yes, sir.
What are the most
नोट करनी है ये बताइए।
diagnosis you can say? What can be the diagnosis here?
ये नोट कर दिया।
Differential diagnosis, clinically.
अब यहाँ तक virtual patient खत्म हो गया। वो
Sir,
कहता है
first
कि डॉक्टर
is
करें सारा, इसकी describe।
my first differential would be a non-union of the neck of femur.
What else?
Then I also think about avascular necrosis of the left head of femur.
What else?
Then
ABN because of fracture or something else?
as it is obvious history of fall, so I'll go with the fracture.
Okay, but I would like to know the multiple diagnosis because he may have the problem.
Then I'll neglected dislocation of the
Okay,
left head of femur.
okay, good.
Yes, sir.
Any other thing?
Pertrochanteric fracture of the left femur.
Okay. Do you find the branch triangle disturbance in the femur fracture?
Sir, branch angle.
So which two most probable diagnosis you would like to keep here? Maybe dislocation, maybe acetabulum fracture, maybe Perthes, maybe Cox, maybe fracture neck femur. Cox, Perthes, you didn't told us. Acetabulum, you didn't told us. But there may be Perthes, Cox, acetabulum fracture. You told the dislocation. What most probable two diagnoses? Let me know and we move forward. Please, hurry.
Endocrine induced
And sir, neglected dislocation of head of femur. One.
Number one. Number two.
Number two is post-traumatic avascular necrosis of the head of femur.
Okay. You would like to say there may be a dislocation and an AVN following the dislocation. Okay.
Yes, sir.
Okay. Can you justify or tell me relevant investigation to confirm your diagnosis?
So the first and foremost diagnosis would be X-ray of the.
So diagnosis, you already told us.
Yes.
We have done the examination. We have done the clinical test. We have done the differential. Now let me know the investigations.
Yes, sir. Sir, I'll advise radiographs, AP and AP view of the pelvis with both hips.
What
and,
else?
And AP and lateral view of the left hip.
What else?
Then I'll also I'll advise.
चलो चलो okay.
X-ray of the lumbar spine also, sir.
एक्सरे दिखाओ बाद में
Okay.
Yes, sir.
Okay, very good.
Yes, sir.
Okay.
Then
This is now second examiner who are asking you. Okay.
starting from the X-ray, when I'll see the X-ray, then I'll decide about the next investigation. What can I say?
And look at this X-ray. This X-ray, after Potter's treatment for 2 months, he was carried to the hospital, and this was his X-ray at the 2 months. What is your diagnosis?
Sir, non-union fracture.
At 2 months.
Yes, sir. So there is a
2 months.
yes, sir.
How
Sir,
would you classify fractures?
sir, Dilbert classification, sir. This one like the subcapital.
Okay. That's all. Listen me.
Yes,
It
sir.
is okay. It is Delbecq division. In which class this falls?
Sir, this is type 2, sir.
What is that called? So number 1 is the.
Subcapital, sir.
No, it is not the capital. It is
No.
words is something else. Words are
Transcervical, sir. Sorry, sir.
transepiphyseal. Okay. This is second. This one.
Is transcervical, sir.
Third one.
Third one is basicervical.
Okay. Let me know any
And fourth is
expected complication. Listen me. Let me know the complications or expected complication in these 3 type of fracture. 1, 2, 3.
Sir,
Which is the most common? In which it is common? Which type?
Sir, type 1 is the most notorious for avascular necrosis.
How much percentage? How much percentage? How much percentage?
It is more than 90% for type 1, sir. And
Type 1 has 2 grades. Type 1 has 2 sub-classification. In which grade is 90 and in which is 100 or 80?
Sir, I don't know that.
You don't know the A and B? Okay,
No, but
we move to the next slide. Okay, this is the patient presented at the 6 months to me, and it was injury, and this was the finding at 6 months. He did not have any treatment in these whole 6 months, except the Potter's treatment and bed rest.
Yes.
So what do you find on this X-ray?
Sir, the most obvious finding is the proximal migration of the greater trochanter, and there is a varus angulation of the neck of femur, and the hip joint looks normal, congruent.
What else?
I can't see the neck actually in this. There is a rotational component also, and
Okay, how would? Okay, so how
triradiate
would you
cartilage.
confirm? How would you confirm in this particular case at this months, 6 months, what is happening at this proximal femur side? How you will confirm? How you will further move?
Sir, I'll advise CT scan of left hip to see the geometry of the of this malunited fracture and the condition of the bone.
Are you sure this is malunion?
This looks like non-union, sir.
This looks, so you have to confirm with the CT. What about in MRI? What do you want to see in MRI?
Sir, in MRI, I will be looking at the head of femur for avascular necrosis.
That's good. Okay, look at the next slide. And we have already done this classification of fractures. Type 1 and type 2, how is managed? How you will manage these cases fresh when you comes to you, type 1 and 2 particularly? And what precaution you would take, extra precautions when you manage type 1 and 2?
Sir, and type 1 fracture, initially the patient is given analgesia and consent is taken, and under fluoroscopic control, I'll pass a we do close pinning of the for type 1.
And what about type 2?
And for type 2, I'll use a cannulated screw.
Okay. What are the precautions you would take in type 2 and type 3?
So in type 2 and type 3, I'll avoid the physis while fixing the fractures.
While performing cannulated screw, is there any technique to see whether it is penetrated the cartilage or not?
Sir, I can't recall, sir.
Okay. What about type 1B? How you will manage type 1B? 1B.
1B is displaced fracture.
Yes, it is dislocation of femoral head. Listen, it is dislocation of femoral head transepiphyseal. How you will manage that?
Sir, I'll do open reduction internal fixation of this condition.
Look at this slide. Look at this slide. This was case managed with probably an osteotomy, uniform osteotomy, and fixation was done.
Yes, sir.
Can you comment on this fixation and the treatment what he had?
Sir, one of the screws is penetrating the physis. There's one or two thirds that they have penetrated it, and the other screw has just missed it. And
what else? Comment. When you do in fresh case, how you will place your screws?
Sir, I'll place the screw in first screw in the center position under the fluoroscopic control, sir. And second screw is put in the posterior inferior position.
Okay, let me know to allow the compression.
Yes, sir.
How you will place the screws? Allow the physical compression in the next few weeks. How you will place your screws? In fact, this is the same question when I was asking the first question.
For compression.
Okay. Let me know any problem in this fixation, post-fixation problems. Can you comment on post-fixation expected problems?
Sir, post-fixation, as physis is breached, there may be physeal arrest, post-operative AVN.
Number one, number two.
Then the heads of both the screws are proud. They can give problem to the patient.
What problem?
It would be uneasy for the patient, painful on the skin, impinge on the skin, sir.
Okay, you want to say at the greater trochanter level here?
Yes, sir.
Okay. What else? Any complication you know more?
Sir, loss of fixation.
One you told the epiphyseal arrest.
Yes, sir.
Okay. What you would have done in this particular case at the 6 months non-union confirmed on the CT scan? What would you have done? AVN, no AVN.
Sir, when there is AVN,
no AVN confirmed on the MRI. There was CT scan that shows non-union.
Yes, sir.
What you would have done instead of this decision?
What
are the options?
Sir, I would have done valgus osteotomy and fixation with pediatric DHS.
Pediatric DHS, okay.
And
okay, what else?
Yeah.
Kafi hai? Doctor Sahab, let me know. You said
Yes, sir.
Okay, what you are talking? Okay, let me know what you are talking.
Sir, I'll also put a derotation screw in it, sir.
With DHS.
Yes, sir.
Okay, just now you were saying it should not cross the physis,
Yes.
and how you hold with DHS, and then again a derotation is screw. Would it not cross the physis?
I'll avoid the physis in all cases.
How is it indicated in transurethral fractures in age of 6 years, 10 years, 8 years, 6 years, 8 years, and in transphysial? Is it indicated? Is it indicated? And in which pediatric femoral neck fractures it is indicated?
Sir, actually, they're indicated for basicervical and intertrochanter type of fracture.
Okay.
But
So we will avoid this PHS in 6 years and 8 years. Okay. So I
yes,
agree with you, the well-defined osteotomy. How you will fix after well-defined osteotomy? Would it be a subtract well-defined osteotomy?
so valgifying osteotomy and
Fixation?
so with partially threaded converted
Is
screws.
there any chance
Yes, sir.
that can get through? How you will pass? You are doing the valgus osteotomy here,
Yes, sir.
and then you are placing the screw from where?
Yes, sir. Sir, I'll use the fixed angle blade plates, sir, to fix it.
Fixed angle blade plate, which type? 4.5 millimeter or the other?
Uh, Sir, I can comment on the size.
Okay, it is better. Okay, we will let you know in discussion. Okay, what else? Any other procedure? I agree with the well-defined procedures. Any other procedure which is usually done in this particular case? Non-unions or partial unions with Coca-Cola?
Uh, the bone grafting.
That's good. When you do cuneiform osteotomy, well-defined cuneiform osteotomy. Okay,
Yes, sir.
then how will fix it? That valgus cuneiform osteotomy is done here,
Yes, sir.
and how you will fix with the bone graft?
Uh,
Any other procedure you know?
Sir, then
Yeah, we move forward.
yes, sir. Sir,
अभी आपके पास 15 मिनट और हैं.
टाइम ही नहीं खत्म हुआ.
सर वो कह रहे हैं टाइम खत्म नहीं हो रहा, ये वाइवा लंबा हो गया है. इसी बात से सर लड़के डर रहे हैं कि वर्चुअल पेशेंट के ऊपर हमारे जो है एग्जामिनर के साथ डायलॉग बहुत लंबा हो जाएगा.
मजा आएगा ना, पास भी तो ज्यादा होंगे. Okay, you do the well-defined osteotomy. How you fix? Is there any biological method of fixation in these structures, particularly these fractures? Biological method.
Sir,
हाँ बोल
sir, the fibular graft.
इधर बोल कुछ नहीं.
That's good. Fibular graft. Which fibular graft?
Sir, fibular strut graft.
हाँ जी पास करेंगे.
Strut तो होता है, उसके बगैर तो होना नहीं है ना. Fibular is a strut. What type of fibular graft do you know?
Sir, sir, ideally, I use vascularized fibular grafts.
Okay, vascularized and free. Is there any other method, biological fixation? In fracture neck femur, maybe in the adults, yeah, adolescents. Okay, we move to the next slide. So this was the next slide at 18 months. At the 12 months post-fixation, he had a started problem and his screws were removed at 18 months. What are the findings?
So there is a collapse of the neck with atrophy of the head, and there are multiple fragments at the lateral edge of the head at the
Okay.
at the base, and
Okay.
there is medial
So what you,
medial migration of the greater trochanter also.
okay, because what, why that is a migration?
Sir, resorption of neck.
Resorption of the neck. Very good. Okay, let me know how you will move further.
Uh, Sir, I'll look at the now the functional status of the patient and the expectation of the patients.
More limp, more entalgic, or not able to go to school.
Yes, sir.
Would you like to see the health of bone?
Yes, sir.
What? How?
Sir,
How?
sir, I didn't get the question, sir.
How you will proceed further to see the health of bone?
Sir, I'll do the bone scan and
What do you want to see?
to see the any infected focus first.
No infected
Secondary to
focus.
infection. Then I'll see the metabolic profile of calcium and vitamin D levels.
Okay. Yeah. Okay, you will do the MRI to see the AV
Yes, sir.
and these things. Okay.
Yes,
And
sir.
what you want to do now?
Sir,
What do you want to do now?
yes,
I think we should remove his femoral head. Hello.
yes, sir.
Hello.
Sir, I want to.
Hello.
Yes,
Are
sir.
you
आवाज आ
listening
रही?
me?
Yes, sir. I'm listening to you, sir.
What do you want to do now?
Sir,
MRI कर दिया, उसने कहा कि AV
avian हो गया सर.
नहीं है, no AVN. What do you, how you will move now?
avian नहीं है.
नहीं हुआ, MRI कहता है नहीं हुआ. अरे बायोलॉजिकल फिक्सेशन करो ना इसमें. Okay, Dr. Zahid, I think this Viva is complete 5 minutes before, and if you allow question answers, then we should do the discussion and then question answer. What do you want?
सर पास हो गए.
ये है ना एक्स्ट्रा मार्क्स ली थी तो ये कैलकुलेशन कर रहा हूँ इन द मई वाइल. मेरा ख्याल में ये he has taken 85 out of 100. कहीं थोड़ी कुछ मिसिंग हुई.
इसमें सर वर्चुअल पेशेंट में जब हिस्ट्री ले रहे होते हैं तो
should we move to the discussion?
सर यहाँ पे लंच पे आ रहे हैं, असल में लंच के बाद हम
ये क्वेश्चन
आप भी
आ जाएगा डिस्कस
कर लें सर. डिस्कशन कर लें.
me I can do after lunch. Okay, we will do the discussion after
कर
lunch.
लें अभी.
What do you say? अभी कर ले क्योंकि 10 मिनट लगेंगे, ज्यादा नहीं लगेंगे. Okay, so his
Okay, sir,
history
कर
was
लें.
6 months old fracture, entalgic lift positive, Edinburgh, Thomas positive, LLD 1.5, Brandt positive, and the Kissick positive. Okay, so first question was the interactive dialogue. Was able to stand, bear weight, how was managed till date, Potter's treatment, he had lubricant, wooden strips, he was taken to hospital but not to the arthropods 2 months after injury, and he was taken x-ray, he was advised non-weight bearing, personal history was normal, he has not taken the history of cough and fever, because second case I had similar examination, similar thing, but he has a Cox TB. Same examination, same history, but X-ray shows the TB. That's why he must have asked the cough, though he had a fall from the 5 feet height. It makes no difference. Complete vaccination history was very important, particularly our BCG, and the family history, chronic illness, wo usne li thi. In examination, it was again an interactive dialogue. 2 marks तक यहाँ पहुँच जाएंगे और इसने इसमें ली थी 1.75 दोनों में ली थी. General examination, posture, gait, sitting ability, Trellingberg test, LD, Thomas test, we done limb length discrepancy, telescoping test. telescoping was very important to know the diagnosis clinically whether he has a movement at the fracture site, and he should have justified all investigation which he had. Therefore, he got the 7.5 marks in this again in case because he was plus minus thoda posture particularly in the gait he could not tell what type of particular gait और बाकी चीजें थी इसमें करने की, right? उसके बाद interrupted dialogue for the systemic examination. Always we say okay there is no significant abnormality. Sometimes we ask okay बर्बर हो तो क्या करोगे? Locomotor system में इसने neurological examination नहीं बताया. न्यूरोलॉजिकल एग्जामिनेशन बहुत जरूरी था बताना क्योंकि न्यूरो डेफिशिएंट भी इसको हो सकता था, और उसकी बाकी तो सिर्फ मायोपैथी की सारी चीजें बताई थी, इसमें ही इज नॉट इन्फॉर्म्ड अबाउट दी न्यूरोलॉजी. बाकी डिफरेंट टेस्ट ही हैज ऑलरेडी टोल्ड अस, inflection contractures, and he has also explained the pictures, but sometimes we keep the simulator. Some we have decided maybe any other assistant may be there and he asked for the realistic examination. Trendelenburg test was very important. On the right side when he stands there is a no fall on other side, but so it is negative, but on the left side when he stands so there is a fall or drooping on this side, and this is the obliquity which happens, and this hyperlordosis in fact he could not tell us is the indication of the fixed flexion contractures. Okay, so this test is positive on the left side. This is the basically mechanics of the Trendelenburg test. If you find these two, correlate these two things, this power is the glutei, this fulcrum is the hip joint, and this lever arm is the on the other side where the body, this is the load. When he bear load, this is the load. So he compensate on this side by bearing the load. Even then, his glutei is not working. Glutei may be weak, or there may be a problem in the fulcrum. So in the next case, you will find in these two particular cases, this is the case which you have seen. There is a non-union. There is a coxa vara. So length of this glutei power is basically reduced because of the drifting of the greater tractus upstairs, and there is a problem in the fulcrum. And same happens when there is a subluxation. So there is a problem of the fulcrum, and this you find in the books. If there is a fulcrum problem, so there can be a power problem, which may be because of neurology, and there may be a fracture that is called fulcrum, or there may be a problem in the load, lever arm. Maybe there is a fracture here, would breaks the lever arm. That's why it produces it. Here is the Thomas Hook-Evan test. Actual Mr. Thomas is there. Particularly, he is. You must exclude. This is basically to demonstrate the fixed flexion contractures, and you must exclude the knee contracture first. And if there is a knee contracture, then you have to do modified test. It is very important, and this is the knowledge we will usually check it. And during this, we can also check. But there is one thing more. What is true and the false contracture? True contracture can happen because of the iliopsoas contractures, or it can happen because of the arthrosis. You may have to exclude these also. Here is the Thomas test, and the errors you usually find there should be hand, there is a flattening here, and modified Thomas test should be done like this, or it should be done like this. Okay. Then there is a branch triangle. Branch triangle, this is the base which you usually check. And if this base is short, it means there is a problem in the neck or the hip joint. If this element is short, then there is a less problem in the below the greater trochanter. This is the finding that this base is short. It means there is a problem in the neck or the hip, which is called the fulcrum and the lever arm, which is problematic. And sometimes you may not do the marking, but you can do with 3-finger test that is called Kissick test in the branch angle. Again, this is the Kissick test, and same in front you can do. Limb length equality procedure and requirements is particularly the squaring of the pelvis must be done when you are doing the true test. And here is the example of the squaring test. You can keep a block test, or you can straighten here. Next, we will show you. If you will not square, then you will finding will not be proper. This is the basically a squaring. This is the apparent test, and this is the true test when the bone length is each bone or from the iliac spine it is tested, which is called true. Otherwise, it is the apparent test. And here is the test of the squaring. How to do the squaring? Squaring may you have to other side limb should be, because there is a flexion adduction contracture here. So you have to keep the flexion adduction of the other limb as well. So there was an apparent contracture and the lengthening on this side and shortening on this side. But when you have squaring and you find absolutely normal, both sides are normal. So there was an apparent contracture because of this hip joint. So there is a no shortening, no fracture neck femur, no pathology, but there is an arthrosis. Therefore, there was a flexion contracture. This is the method of the doing squaring of the pelvis. So X-ray, you have already done 2 months dealt with the collapse fracture, non-union was there. So we do the inflammatory marker sometime. And in this particular case, as other case, I have a tuberculosis. So you must do these things and then additional tests. This is the classification which already done. So here this is dislocation. It is the without dislocation and with dislocation. With dislocation means type 2 and without dislocation matter. And the AVN usually is the 100% in type 1, particularly with dislocation. But if there is a no dislocation, there is an 80 to 38% of AVN. And same is the non-union is not here, but non-union can occur in other fractures. Most common is with the transcervical or cervical tract injuries. And AVN decreases gradually from the type 1 to type 4. Type 4, there is 5% decrease. Here is the methodology of treatment options in the age group wise. Below, this group was basically in the 4 and 10 years age group. So the cartilage, you have to place the dye through the hole of the screw, and that will let you know that dye is going to the inside. Yeah, you can also place the air. The joint, if it is going in the joint, it means that it has penetrated the joints. Hello, listen me. Can you listen me? Hello.
आवाज आ रही है, आवाज आ रही है.
Hello.
जी सर, आवाज आ रही है.
आ रही है तो बस ठीक है, फिर चलते आगे. तो टाइप ओके, टाइप 5 में यूजुअली DHS या जो फिक्स्ड प्लेट एंगल्स पीडियाट्रिक की आती है ना, वो दैट इज वेरी इंपॉर्टेंट एज कंपेयर, बिकॉज़ देयर इज अ गुड नेक available to fix this but not type 3. कहीं भी नहीं देखोगे DHS यहाँ पे इस्तेमाल हुआ या plate, but here you can have a side plate, you can have a side plate, but particularly after 10 years of the age. So here was the treatment options. In this particular case, only wedge osteotomy cuneiform was done, but the options of treatment here is the wait and watch. Preserve, femoral head must be preserved, and you can treat it as Perthes, or you can place a vertebrofibrigra, or you can place a Jude graft, which was biological. I missed right here, and I think it is okay. Thank you very much. अभी घंटा पूरा नहीं हुआ, 9 minutes फिर भी बाकी है.
Thank you so much, sir.
Any questions? Any question?
सर से एक बात, अपना नाम बता.
रिकॉर्ड किया जाए.
मेरा नाम डॉक्टर सफदर है सर. अभी सर हिस्ट्री एग्जामिनेशन के बाद आपने सारी चीजें खुद ही कंपाइल करके रख दी हैं कि ये पॉजिटिव फाइंडिंग्स थी, तो ये एग्जामिनर वहां भी ऐसा करेंगे या हम उनसे अगर टाइम मांगे कि सर 5 मिनट दे दें, हम ये सारी चीजें कंपाइल कर लेते हैं, टाइम दे देंगे या फौरन ही आगे चलेंगे प्लान की तरफ?
नहीं, बेसिकली जिस वक्त मैंने ये कहा था ना कि ये चीजें देखो कंपाइल करो, रिकॉल करो, तो वो हमें हमेशा टाइम देते हैं, पहले भी देते हैं, और इसमें तो ज्यादा देंगे टाइम. पहले तो हम बैठ करके सुनते थे, इसमें तो हम कहेंगे ठीक है जी रिकॉल करो, कागज पे लिखना चाहते हो रिकॉल करो, हम भी 2 मिनट रेस्ट कर लेते हैं, आप ये इसी तरह से रेस्ट कर लो, और फिर जो है बाकी जो है डिफरेंशियल डायग्नोसिस उस पे हम चले जाएंगे. इट इज ट्रू. वेरी गुड. नेक्स्ट.
पेपर सर कोई प्रोवाइड कर रहे हैं CPSP वाले जिस तरह पहले करते हैं, या कोई शीट वगैरह लेके जा सकते हैं एग्जाम में?
पेपर बिल्कुल प्रोवाइड करेंगे, पेपर प्रोवाइड करेंगे. बाकी इंस्ट्रूमेंट सबको लाना होगा, ये नहीं समझना कि सिर्फ अप्रन पहन के चले आना है. हो सकता है कि जनरल जाए
मेजरिंग टेप सारा कुछ लेके जाना है आप, क्योंकि वो कह सकते हैं कि इसके ऊपर कोई टेस्ट करवाएं. बस
वो भी कह सकता है कि मैं लेटता हूँ, मेरी थॉमस टेस्ट करो भाई, मेरी टेंलिन पर टेस्ट करो. तो अगर वो थॉमस टेस्ट करनी या कोई लिम्ब लेंथ इक्वलिटी करनी पड़ी तो कैसे करोगे? मेजरमेंट तो आपके पास होनी चाहिए. आपकी लवाजमात आपके साथ जरूरी है. जी जाहिद.
सर थैंक यू वेरी मच.
ओके, वाज इट फ्रूटफुल?
जी सर, वेरी यूजफुल.
पहले वाली भी रिकॉर्डिंग मौजूद है, लॉन्ग केस की, शॉर्ट केस की, मैं इंशाल्लाह आपको भेज देता हूँ.
ठीक है सर, ये मैं सेव कर रहा हूँ रिकॉर्डिंग सर, हम शेयर कर लेंगे आपके साथ.
थैंक यू.
थैंक यू सो मच.
ओके, थैंक यू वेरी मच.